The contaminated airway is one of those problems that gives every clinician, no matter your level of expertise, anxiety. Blood in the airway, vomit, debris, you're blind. Your camera becomes obscured the minute it contacts fluid, and if you're not able to stay ahead of it, then direct laryngoscopy isn't going to be helpful either. That moment has been happening in emergency departments and the back of ambulances for decades. And for most of that time, providers were managing it with tools and techniques designed for a clean OR. Dr. Jim DuCanto is the anesthesiologist who decided that gap was unacceptable. He invented the DuCanto catheter and the salad technique, suction-assisted laryngoscopy and airway decontamination. Today, Will Berry sat down with Dr. DuCanto after his talk at FASTCAN to discuss about how salad works, why simplicity and portability in suction devices aren't just a nice to have, but imperative to the mission, and what it looks like when an anesthesiologist decides that pre-hospital providers deserve real tools and real training for the calls that go sideways. This is Loud and Clear. Let's get into it.
You on 8? You on 8. Okay, you're clear. Stand by for your base.
Will here for Loud and Clear, and we're at FASTCAN. I'm here with Dr. Jim DuCanto, who just spoke about salad airway. And Dr. DuCanto, thank you so much for sitting down with us.
Well, thank you very much for inviting me. I'd love to chat with you.
Yeah. First off, I wanted to get a little background. How did your relationship with pre-hospital providers first get started?
Gosh, I think it has to do with social media, in all honesty. I think what had happened was that I started getting active on Twitter about maybe 2011. And my relationship initially was with the bloggers, especially in Australia. And what happened as a result of contributing to their blogs, as well as the blogs here in the United States, particularly Scott Weingart's blog, MCRIT, was I began to kind of entrain a larger group of people who were interested in learning and contributing and just kind of meeting at meetings. And because I was doing simulation doing these interesting simulations, a local group of paramedics in Milwaukee just sent a message to me through Facebook Messenger, and we got together, and those guys ultimately ended up really, really taking this to heart. And I had a growing interest in EMS education through interacting with you guys. You showed the interest, you showed up, and it gave me an opportunity to play, as it were, with these simulations. Doing this stuff alone is boring, but when you have people who want to learn and you also learn from them, we ended up inviting paramedics from other suburban departments around Chicago up to my airway lab in Milwaukee. And one of the things I discovered about the contaminated airway was that it's a very intimidating, daunting problem for paramedics. I had this one guy, an experienced paramedic from a suburban department in Illinois, who stepped up to suburban Chicago department. He stepped up to the salad simulator, and the guy took a few deep breaths, and then he held his breath, and then he did the simulation. And what I saw was I saw fear, loathing, and anguish in this man's body. And what happened was that he did the simulation four or five more times, and I realized that this was not just a learning opportunity for this paramedic, it was a cathartic moment of rewriting history in his own head. How could he have done a better job? How could he have not failed in these situations that he faced throughout his career? And I thought to myself, gosh, I didn't really realize I was setting things up that allowed people not simply to learn something, but potentially to heal from past airway trauma.
Right.
Not patient trauma. It's the paramedic airway trauma. Like,
right.
Wow, man. So moving on from that, I decided to continue to try to innovate, and I ultimately brought my ideas to NASCO Healthcare, who had a big center in Wisconsin at the time. Since then, they've moved the center east to upstate New York, and I brought the concept to them that this was an easy modification of an existing airway mannequin, and they had faith in me. They created the product, and in many ways, the rest is history. My concept was to keep a low-cost, very durable airway trainer, Airway Larry, which has been marketed since 1969, by the way. That's an old mannequin. But put it into a different format where what the paramedics and their students can do is properly position the mannequin for intubation in a head-up position, can be strapped to a gurney. You can put it in a helicopter, put it in an ambulance, put it under a table, put it in a car. You can do anything you want with it.
Right.
And when you're finished with it, the case, which is the torso, serves as a receptacle for all the airway training materials. So I took it from simply being a head on a board to something that could be dynamically positioned, and we gave you everything that you needed to do the technique. So that was NASCO. Now, the DuCanto catheter was something that was developed as a collaboration with a company called SCORE Incorporated in suburban Los Angeles. And what I had done with one of their products was I took their existing product, which is called the high D catheter, and I simply changed the shape of it to make sure that it could properly work with hypercurved video laryngoscopes. They had faith in me, and they produced that DuCanto catheter. That's what you're seeing now.
Right.
The DuCanto catheter has made a major difference because of the versatility of the shape, as well as partnering it with a concept of suctioning first, being proactive in using the suction catheter to decontaminate ahead of the video laryngoscope. I actually have convinced a physician who's written guidelines for difficult airway management in the United Kingdom in ICU medicine that in cases of the blood in the airway, they were recommending direct laryngoscopy because of the potential for failure of video laryngoscopy in those cases.
Contamination of the camera.
And what I taught them at the 2019 World Airway Management meeting with my lecture, or actually it wasn't the lecture, it was the workshop. They didn't give me an opportunity to lecture. Was say, oh gosh, you know what? The video laryngoscope will not fail under these conditions if you use a proactive suction technique. Oh gosh, interesting.
So also the simplicity of just a larger bore.
Yes, the simplicity of a larger bore. The product upon which the DuCanto catheter is based is a product called the High D. It had been marketed since 1988. It came with a vent hole, which required you to cover it with a thumb or a finger or tape. If you put tape over it, you're violating the instructions for use. I mean, there's several things that can happen with that. I didn't pull out the bougie in my pocket to put it through the DuCanto catheter, but it does violate the instructions for use to put a bougie through the large bore sucker, otherwise known as the DuCanto catheter.
So walk me through the steps of SALAD.
Okay, so what you're going to do is, as best you can, is optimize the patient positioning and pre-oxygenation prior to using the technique. You'll begin by pushing on the chin to open the mouth enough to place the suction catheter, rigid suction catheter, mainly midline around the base of the tongue, suctioning left and right. And then you're going to use the suction catheter in your right hand, held like a laryngoscope, upside down, so that the suction pointy point is away from you, down and away. You're going to push the tongue into the floor of the mouth, and then you're going to create a lifting motion, just like with direct laryngoscopy, but you're going to be doing with your right hand, not your left hand. That is going to open the oropharynx and the hypopharynx in one move, allowing you to place your laryngoscope over the base of tongue carefully without allowing any airway contaminants to contaminate the light or video source of your laryngoscope. As you reach the base of the tongue, you'll have to readjust the suction catheter somewhat so that you don't trap the suction catheter under the laryngoscope. What you'll then do to maintain hypopharyngeal decontamination during the procedure is remove the suction catheter and place it down the left side of the laryngoscope. It can be done where you move it around the laryngoscope, but it doesn't work in patients very well. I teach, take it out, put it back in. Before you perform the tracheal tube delivery maneuver, you have to be conscious of the fact that you may have a compromised space for tracheal tube delivery. That is one of the problems I've identified with the use of the glide scope, having nothing to do with the SALAD technique. So I will commonly stick my right index finger in alongside the laryngoscope to make sure that the laryngoscope is not towards the right corner of the mouth, it's more towards the midline. And if the tongue is hanging over the tracheal tube delivery path, I can push the tongue to the left of the laryngoscope blade with my index finger. It's akin to dilating if you're placing a central line, you'll perform a needle, a puncture, and a wire, a nick with a scalpel, and then dilating the tract before you place the catheter. So I'm using this as a dilation technique. Right. You place your tracheal tube, and then the next technique should be, if you can, is to suction the tracheal tube before ventilation. And I didn't put that in my lecture, but I just had to I wanted to make sure I didn't take too much time giving the talk today. I want to be respectful of the audience and the time they gave me. Yeah.
Well, one thing I wanted to touch on is just, I met you only moments ago, and after your lecture, a lot of pre-hospital providers are coming up to you and saying, I've used your technique, I've used your equipment, and I was successful. Does this happen a lot to you? And what do you think this speaks to?
It does happen quite frequently. I think that there's a lot of gratitude among individuals in emergency medicine, pre-hospital medicine, with the simplicity and the effectiveness of the tools as well as the technique. And my goal has been to be as open source as I possibly can in sharing this. And I think that this is possibly the dividend, the payout that I get, is that I have made it my little role to sort of bring this into the world and then give it away. And then I simply say to individuals like this is just, okay, it's up to you now to make sure that everybody that you call is your partner or falls under you learns this. So it's your job to pass it on, because I won't be here forever. It's up to you. We've made this incredible change in the last 10 years, really, in airway management, in the contaminated airway. I have no idea what the dividend of that is going to be for pre-hospital medicine, but I know it's a big thing. I really do know it's big. But what are you going to do? That's one thing I've done. I've got more to do.
I think it's great. You know, paramedic education, there's a lot centered on intubation. It is a skill that is performed in the field. We're usually doing it either on a mannequin or in an OR. We do get to go in a very controlled environment. And then when we go out into the field, it's a very uncontrolled environment. And so I think it was impressive to me to watch people engage with you, because I think it's kind of like, finally, someone has taken an interest, someone that is an industry professional has taken an interest in our environment and is giving us tools and training to help us be successful in that.
Thank you for saying that. I have to say a few history points here for your viewers or your listeners that through my travels and simulation, I've discovered that Airway Larry was marketed in 1969, but the mannequin it was competing against was the original Laerdal Airway trainer, which we're all still buying. That came out either in 67 or 68. That's how old that mannequin is. And when I read Kevin Hazard's book, American Sirens,
right,
and I've read it twice by audiobooks, what I've discovered is that, and I've seen this before in paramedic education, is you all are somehow gauged to judge your awesomeness, your competency, your ability with intubating the patients. Okay, so that is something that I wouldn't exactly say has to die on the vine. I think what needs to die on the vine is the concept that you have to judge yourself and how good you are by whether you can intubate or not, because you've had too large a number of problems making it impossible for you to intubate. That's number one. Number two is, why did the Laerdal company make that airway trainer when it was Peter Safer who got Ozma and Laerdal to make the original Recessa Annie in 1959, 1960?
I don't know.
Well, I look at this, and there isn't anybody around who's going to be able to answer this question, but I can bet you a lot of money that Ozma and Laerdal's company made that airway trainer for Peter Safer, who, if you look at you read Kevin Hazard's book, you'll discover that Peter Safer had it in his heart that he wanted the pre-hospital clinicians he was training to be able to intubate pre-hospital. And he had to put that off until the early 70s instead of the late 60s, but he was training them on a model. I believe that Laerdal made that model because Peter Safer wanted it. That guy who created CPR, that guy who's known as the father of ICU medicine in the United States. That's how important this guy was. Right. The guy after what the Safer Institute of Resuscitation's named in Pittsburgh. I look at this and I say, and my eyes get wide, because I say, wow, this is, if you want to discover something interesting, you discover what the connections were that made things like this happen. Incredible things. Peter Safer, of course, the guy had the right idea, but he was an anesthesiologist. But that guy, he always had 10 projects going at once. The guy's a visionary. For me to be able to somehow kind of maybe clean off the dirt and put a shine on something that Dr. Safer did, well, that's pretty cool, man. I mean, that is pretty cool. I wouldn't put my innovation here at his level. I'd simply say, well, Dr. Safer, this is a detail, especially in light of the fact that Dr. Safer never really saw the advent of video laryngoscopy. He was retired before the 2000s. I think he passed away 2008. But nobody saw what our current challenges are in the 21st century.
One thing that you kind of ended your talk with that really resonated with me. I worked the predominant amount of my 911 time in a system where our suction unit was big and cumbersome.
Yeah.
And, when you're going into a cardiac arrest or a patient where you anticipate airway management, you're taking a lot of things with you.
Yeah.
And so you end up having to make a decision.
Yeah.
Do I want to take it or not? And you shouldn't.
Yeah, that's right. And the video I showed, I cut a couple of my videos short. And in many ways, the video that I displayed was really almost an advertising video for that new device. And I understand that I'd love it that this thing could be available immediately in Canada as well as the United States. That's not the way things go. I think it might be a couple of years before we can get it into Canada. But we're going to put, basically, it's probably about the size of that instrument down there that's on your table.
About the size of a book, kind of.
Size of a book. I don't know what the implications are of this device, and if it's able to do what we hope it does, I think we're looking at incremental improvements in resuscitation. So we have incremental improvements in resuscitation. We're getting better incrementally. We have technologies helping us, but also training and wisdom and skill is helping us incrementally. We're going to continue to get better. It has been said in the 19th century, everything that is invented has already been invented. And we can kind of look at that when it comes to medical technology, but you know that that's not true.
Right.
You just know that it's not practical to use some of these techniques. It's not practical to do this or do that, but we can do the things that we can carry and we can afford. And so the beautiful thing is I wouldn't consider myself really an industry person, mind you, but I am completely conscious of the fact that if I make something that doesn't do what you need it to do, when you need it to do it, it doesn't work and you can't afford it, then it's worthless.
Right.
Really. I mean,
Yes.
and that goes for whether it's a simulation product or a clinical product. So I think we're going to see some interesting things in the next 5 years. I know the United States military has been publishing papers for the last 20 years on trying to improve battlefield suction. And there isn't anything out there that fills their weight, space, and performance requirements. And it remains to be seen if the United States military loves the gadget that we're going to put on the market this year in the United States.
Well, traditionally, I think portable suction devices, they always compromise something.
Yeah,
They're either big or if they're small, then they don't suck enough.
They don't do the job. Then they don't do the job. We all have to understand that. I don't think we're ever going to get rid of vacuum powered suction devices. We still need them. You can suction extract things with a powered suction, but you require a compressor that puts airflow through a solid suction container. And one of the most impressive stories of salad I ever heard was in Lincoln, Nebraska. After I did a big salad course in Lincoln, Nebraska, they RSI'd a patient still trapped in a car after a side impact to the passenger door of the front seat occupant. And when the paramedic was finished intubating, he looked over at his suction machine and there were broken teeth in the suction container. And I said, oh, I didn't know that the DuCanto catheter could do that. That's very interesting. Wow.
Mm-hmm.
That's amazing.
Yeah. You mentioned two possible negative, not outcomes, but negative things that can happen.
Sure. You have to look at the downsides of salad. So the first thing is that potentially with what I've described as salad, if you're using continuous suction, that when the catheter is going in, you could literally trap the uvula in the suction catheter, or you could trap a pharyngeal mucosa with the suction catheter. Ironically, I asked SCORE to remove the thumb hole port on the DuCanto catheter, but what I created potentially was another problem. So potentially you can still adhere to mucosal surfaces in the pharynx. That's one problem. The second problem is that potentially we are sucking out our supplemental oxygen if we're using a no desat nasal oxygen during an attempt to secure a tube, no desat, which is 15 liters a minute or greater of nasal oxygen during the intubation attempt. You're sucking all the oxygen out. You're sucking it. Well, at least in my little graph there, it went down to 40% FiO2 in the hypopharynx. So if it's a prolonged intubation attempt, you're pulling out the supplemental O2.
Yeah.
The third problem, of course, is the physical size of the unit. If you can't carry it, you don't got it. If you don't got it, There's the most interesting sign I ever saw on the side of a grocery fruit stand truck in Chicago was, if we don't got it, you don't need it.
Well, I wanted to quickly say, so when I first met you just a moment ago, I kind of bombarded you with this this image, which was a graphic image of a airway that I had to manage. So first off, sorry I bombarded you with that.
No, that's okay.
But second off, I wanted to tell you that I had been called in to manage that airway not long after receiving good salad training. And this was a gunshot wound to the head.
Oh my.
That we ended up utilizing 2 of your catheters at the same time.
Yeah.
Using video laryngoscopy and a bougie, and we were successful. And it was solely because of the training and the technique.
Wonderful.
And the transfer of knowledge.
That's wonderful.
So yeah, I wanted to take the moment to tell you that, and thank you.
Sure. And what I'll let your listeners, viewers know is that I am continually learning. I ran a seminar for the University of California, Davis Department of Emergency Medicine. I was one of the stations in their annual Airway seminar for emergency medicine residents and students. And I had 2 junior instructors, and one of them was their Airway fellow. And what she showed me was how they approach airways in the emergency department. And how do the emergency physicians approach this when they have the resources? They use 2 suction catheters, not 1. They use 2 large bore suction catheters. And they will quite often, if they're in a hurry, they'll put a bougie literally with a large bore suction of the sort that the DuCanto and the high D are. You can actually accommodate a 14 or 15 French airway intubating catheter or bougie through the catheter. That's an off-label technique with the device. I'm required to say that as the inventor of the DuCanto catheter. But this is a technique that's really actually growing speed because it simplifies airway management to the point of suction, laryngoscopy, placing the catheter within close proximity to the larynx, popping off the hose, and then putting the airway intubating catheter through the suction device. I have a name for it. Some people have a name for it. I call it suction-assisted airway catheter insertion. I have a colleague in the Netherlands that gives it a different name, but that's fine. You know, my acronyms aren't always that good either. But what we have here is we have something that it'll be in 10 years. I have no idea what this is going to look like. I have an idea, but I'm interested to see what you guys do with it. I'm going to bring it, and then you're going to use it because I ain't going out there. I'm not going to do what you're going to do. I'm going to stay in the hospital and maybe even not even for much longer. I'm going to continue to help you guys, and I'll train mostly in simulation. Rather, I do have paramedic students who come in the operating room with me. I try to train them on models before I let them touch the patients. And I try to put them in a position where they can be completely successful. Learning through failure is great, but when we have elective surgical patients, it's better that, in my opinion, this is just my opinion, but I think you guys should just listen to me. If you're sending paramedics to hospitals to learn to intubate, they should always intubate with video laryngoscopy. Number 1, they'll always get it. Number 2, they'll see what the hell they're doing. Number 3, there's essentially very little risk to the patient. Number 4, if the paramedic students don't create a problem for the supervising anesthesiologist, then there's no reason why the anesthesiologist won't let them come in and work. So the anesthesiologists within North America need to know, stop forcing paramedic students to use direct laryngoscopes on patients. Don't tell me that they're not going to have it. That's wrong. Just like, I mean, it's ridiculous. Of course, they're going to video laryngoscopy. Not only are they going to have it, we're going to require it, and the medical directors are going to be looking at the footage that comes back to them.
Right.
So we are going to make this switch. We should stop talking about this topic of training on direct laryngoscopy. Sure, you can know how to do it, but so what? So what if you can do it?
Yeah. What kinds of ideas, innovations, thoughts do you have around, you know, the DuCanto or any suction catheter, but specifically your large bore one?
Yeah.
So essentially sucking out the oxygen during your attempt, but you need that. You know, you are there any methods, tricks, or maybe ways in the works to maintain that oxygenation during suction?
What you could do, obviously, is just disconnect. You could kink the suction hose. You can just occlude the hose by kinking it if you have somebody. And I realize that there are those of you who don't have a lot of people helping you, and there are those who have plenty of people around. You could either disconnect the hose from the suction catheter and complete the intubation, or you can kink it. If it did have a thumb hole, maybe that would make things better. But what it would do is just reduce the effect of suctioning out.
Right.
The oxygen. You're still going to suck it out. Yeah. We don't have high flow nasal cannula yet for pre-hospital use, but I actually am working on it.
Oh, wow.
It's an interesting project I have where we may be coming out with this next year in the United States. We'll see. We'll see how this goes. These projects, they almost take decades to get going, but I've got an interesting, I've been helping on an interesting company potentially produce this. So, but you'll get much higher flows with that, but you still have the same problem with a vacuum powered unit that you potentially are vacuuming out your supplemental oxygen.
Yeah.
Yeah.
You mentioned the device that the smaller suction device you're working on is not vacuum powered. Is that correct?
That's correct. It uses a fluid pump technology. So it's a self-priming fluid pump.
So once it detects fluid, then it starts
runs up the hose.
Yep.
The device will cycle, and it'll only pull 750 milliliters of gas per minute versus liters per minute of liquid. Okay. So what you're looking at is something that actually I have not measured the fluid flow rate, but it's fast, but it's only pulling 750 milliliters a minute of gas compared to between 24 and 38 liters a minute of gas in a vacuum pump, rigid suction container manufactured system.
Mm-hmm. For if there's any pre-hospital provider listening that doesn't have a specific salad trainer, what are some ways that they, even on just their next shift, could mentally prepare for a contaminated airway?
If you want to perform the intubation attempt with consciously envisioning holding the rigid suction catheter upside down with the tip facing away from you, almost like you're holding a Macintosh video or laryngoscope blade, place it into the mouth of the mannequin. And then what I want you to do is swish it left and right. And then I want you to put it in the midline of the mannequin's tongue. And I want you to push the tongue to the floor of the mouth. And I want you to lift like you're doing direct laryngoscopy. Then I want you to put the blade in right over the top of it, right over the top of the suction catheter. Then I want you to untrap the suction catheter from under that blade, put it into the field of view on the right. And then I want you to take the suction catheter out and deliberately come inside your wrist, not outside, to place it to the left of that laryngoscope blade, parking it just above the esophageal inlet or the esophageal, underneath the larynx. Yeah.
That's great. Well, Dr. DuCanto, thank you so much.
Oh, you bet.
I've personally benefited from your innovations, and so I really appreciate it.
Yeah.
And I know that our listeners do as well. So thank you so much.
Thanks so much.
Yeah, nice to meet you.
Thanks so much.
Dr. DuCanto said something in this conversation that I haven't been able to shake. I won't be here forever. It's up to you. We're no longer talking about suction catheters, but instead, what happens when knowledge stops moving forward. So take these principles with you. First, be proactive with your tools. The contaminated airway is not when you figure out your suction setup. Figure it out and train it before the call. Second, simulation is a chance to get it right the second time and set yourself up for success on the third time. That's what deliberate practice does. When you deliberately train where you stumble until you don't, it not only teaches you the skill, but it's an opportunity to heal from past mistakes and to prove to yourself that that mistake won't happen again, giving you the confidence to move forward. Third, pass it on. Every technique you've learned, every hard call you've worked through, someone behind you needs that. And we highly underestimate the value of social learning in our careers. If you can carry it, carry it. If you know it, teach it. For more on the salad technique itself, check out our episode entitled The Art of Laryngoscopy, released March 1st, 2024. And if this is the kind of thinking you want more of, we've got two ways to go deeper. Our free newsletter, The Confidence Dispatch, comes out weekly. Real frameworks that help you close the gap from where you are to where you want to be. Real talk, real lessons learned the hard way, no fluff. Sign up using the link below. And if you're ready to really get serious, coaching, mentorship, a community of like-minded paramedics pushing each other to be the best they can be, the Paramedic Confidence Builder Fellowship is waiting for you. Link to learn more is in the show notes. Until next time, stay safe out there, and remember, what you do matters.